Thank you so much, and it's an absolute pleasure to be here. Let me just give me 1 second to work this out. All right, I got this. So it's an absolute pleasure to be here, and tonight I'm going to talk to you about really the intersection between communicable and non-communicable diseases. And look, when we talk about non-communicable diseases, we're really talking about a broad spectrum of conditions. So tonight, just for the interest of brevity, I've decided to focus in on one. I was actually going to do obesity, but now that I'm the dinner talk, I think it's really good that tonight I'm chosen to talk to you about diabetes. Maybe. So we know for a long time that diabetes is actually a risk factor for both severe influenza as well as other respiratory conditions, including COVID-19. So there's lots of evidence for the role of diabetes in the severity of influenza. You can see just some of the literature here from clinical studies, from experimental studies, and sort of the sum up of the information is that generally if you're living with diabetes, you have a 3 times increased risk of being hospitalised with influenza. What's interesting is we don't really know if this is more prevalent in individuals living with type 1 or type 2 diabetes. This is actually a major flaw of the research in this field because generally studies just talk about people with diabetes as one group, and of course we know it's much more complex than that. But perhaps not surprisingly then, we saw very much the same thing with COVID-19. So this was a study that we did looking at COVID-19 severity in different hospitals around the world. And importantly, when we talk about diabetes, diabetes is often co-associated with a lot of other chronic conditions that could increase the severity of respiratory virus infections. So in this study, we were adjusting for things like BMI, age, sex, pre-existing cardiovascular disease, hypertension, pre-existing respiratory disease, and even when we adjusted for all that, you could still see that diabetes increased the risk of severe COVID. So there's 2 main hypothesised mechanisms by which diabetes increases your risk of a respiratory viral infection. The first is chronic inflammation. And the idea is that diabetes is associated with chronic inflammation. We know that. That creates a baseline level of inflammation such that when you're then infected with a respiratory virus, you get a hyperinflammatory response, you get that cytokine storm, and you get damage. The alternate theory is that metabolic diseases, in particular like diabetes, actually impair T-cell immunity, which we know is really important in protecting against respiratory virus infections. So there's good evidence that diabetes can do things like decrease T-cell migration, reduce cytokine expression after stimulation, and also result in a higher accumulation of senescent T-cells. So when we think about this, we're talking about mechanisms. So it could be chronic inflammation, it could be T-cell responses, but what is it about diabetes that is driving these changes? And the most obvious place to start would be hyperglycemia. And I say this is an obvious place because it's one of the key defining features of diabetes, but also we know it's one of the features that's the same that's shared between type 1 and type 2 diabetes. So hyperglycemia can be measured in a variety of different measurements, but typically this is measured by a patient's HbA1c, which is a 2 to 3 month average of glycosylated hemoglobin. And there's different HbA1c targets set for different populations, but in general, you have individuals who are of a normal HbA1c, individuals with a pre-diabetes HbA1c, and individuals with diabetes. So we wanted to see if hyperglycemia was driving this response to diabetes and this increased disease severity by increasing the inflammation. So that first hypothesis I talked to you about. So what we did is we took PBMCs from healthy donors, we cultured them in the lab in either hyperglycemic or normoglycemic conditions. We then came back and challenged them with influenza, and we looked at the inflammatory response. So what you can see here is you can see that in the blue, we have the cells that have been incubated in normoglycemic conditions, and in the red, cells incubated in hyperglycemic conditions. So the lines indicate cells came from the same donor. And what you can see is if you stimulate these cells with a mop, you don't really get any response. But if you stimulate with influenza virus or a viral mimetic, you can actually see an increased inflammatory response in the hyperglycemic cultured cells. What's really interesting about this is if you actually go to the experimental setup, what you can see is that these cells were only incubated in hyperglycemic conditions for a day. They were then put back to normal glycemic conditions for 6 days. So this is not just the effect of hyperglycemia, it also seems that your cells can remember the history of hyperglycemia. And you can imagine what sort of implications that would have for patient care. So we then wanted to see if this hyperglycemia was associated for the second hypothesis I told you about, which was affecting T cell function. So what we did is we recruited donors who were living with and without diabetes. You can see the donor characteristics here. Importantly, you can see that there was a difference in the BMI, which is not surprising, and importantly, a difference in HbA1c. What we then did is we looked at T cell function, and there's lots of different functional assessments of T cells, but one assessment we looked at was the production of TNF-alpha. And what you can see is that even controlling for differences in BMI and age, there's actually a negative correlation between HbA1c levels and TNF-alpha production by T cells. And you can see this if you actually match your two cohorts in terms of BMI and other factors. So hyperglycemia plays a role in the susceptibility to severe respiratory virus infections. But one of the things that's been emerging in the diabetes field over the last 10 years is that hyperglycemia is probably a bit of an oversimplification. And we can see this now with the availability of constant glucose monitoring devices, or CGMs. What we know is that you can have two individuals who have the same average blood glucose, but one individual will have high glycemic variability, where the blood glucose will bounce like that throughout the day, and one individual will have low glycemic variability. And there's sort of an awareness from the non-infectious complications of diabetes that this glycemic variability plays a really important role in disease prediction. There's different ways to measure this glycemic variability, but one standard measure is looking at the coefficient of variation. And just one point to note, there has been one study that's come out in the context of COVID-19, again suggesting that this glycemic variability, or this bouncing of blood glucose levels, is implicated in disease severity. So to answer this, we recruited patients with diabetes who had CGM data available, and we divided them into two groups based on their glycemic variability, a high and a low glycemic variability group. And what you can see here is really nicely that these two groups are matched in terms of things like diabetes duration, average blood glucose levels, and it's just their glycemic variability that sets them apart. If you then again look at their T cell responses, what you can see in terms of T cell function is that these two populations, so CD107 and TNF-alpha positive and just TNF-alpha positive, are significantly lower in the individuals who have this high glycemic variability compared to people with diabetes who have low glycemic variability and compared to a healthy cohort. So I would caution people to assigning all this susceptibility of people with diabetes to respiratory virus infections just due to hyperglycemia. I think it's much more complicated than that. Okay, of course, we're all here at an immunisation coalition meeting, so you're probably wondering about what is vaccine efficacy like in people living with diabetes. So in general, when we talk about SARS-CoV-2 vaccination, generally people with diabetes have equivalent humoral and cellular immunity to people living without diabetes to the SARS-CoV-2 mRNA vaccinations. That's really good news, but this has also been a bit inconsistent between studies, and this is largely due to factors like it depends on the diabetes subtype, it depends on the duration of diabetes, it depends on what type of mRNA vaccine you're talking about, it depends on the time post-vaccine. So there's a lot of confounders here that haven't been successfully addressed. And as a result, you do have some studies suggesting, for example, this study here, that the immune response to SARS-CoV-2 vaccination is impaired in diabetes. When we talk about influenza, generally the message is the same here, where in general, the influenza vaccine is seen to be equally efficacious in people with and without diabetes. So again, very good news. But there is a really lack of evidence here controlling for all these confounders. Now, one of the really important things to note about this intersection between communicable and non-communicable diseases is that it's actually a bidirectional relationship. So diabetes increases your susceptibility to respiratory virus infections, but also respiratory virus infections can increase your susceptibility to diabetes. We haven't seen this so much for influenza, but it's become very, very clear with SARS-CoV-2. So there's a lot of studies here for your interest. All of them are generally suggesting that post-SARS-CoV-2 infection, you have a higher risk of diabetes, and this is both type 1 and type 2. So again, because this is an immunisation coalition meeting, oh, did I skip a slide? Oh no, we're good. You're probably wondering, why is that? What is it about these respiratory viruses that increases this metabolic dysfunction? And at least for SARS-CoV-2, this paper here has shown very, very nicely that SARS-CoV-2 can actually infect and replicate in the pancreas. And that this infection and replication, which you can also see in the autopsies of SARS-CoV-2 patients, this actually causes beta cell dysfunction. So there is a proposed mechanism by which this relationship occurs. Now, the next obvious question is, if this relationship exists in infection, does it exist in vaccination? Well, the good news is probably not. There's been extensive studies looking at the risk of diabetes development after SARS-CoV-2 vaccination, and the general consensus is that vaccination actually lowers your risk of SARS-CoV-2-induced diabetes, and that, again, vaccination plays an important role in reducing the severity of SARS-CoV-2, but it doesn't seem to be associated with any signal for an increased risk of metabolic disease. So just to sum up what I've told you, what we really now know is that vaccination against SARS-CoV-2 and influenza does decrease the risk of severe respiratory virus infections in people living with diabetes, but there's a lot of caveats here and a lot still that we need to explore, including things like the type of diabetes, the time post-vaccination, the type of vaccination. We also know that vaccination is really important in reducing the risk of diabetes following SARS-CoV-2 infection. And as I presented to you, that this susceptibility of diabetes to respiratory virus infections, probably hyperglycemia plays a role, but probably it's much more complex than that. And really, if we start talking about glycemic variability playing a role in the susceptibility to infectious disease, it does raise issues about trying to improve the availability of constant glucose monitoring devices, and not just for individuals living with type 1 diabetes, but also living with type 2 diabetes. So I'd just like to thank everyone who made this work possible, and just a shameless promotion following on from Ian. We are holding options for control of influenza in Brisbane this year. If you have any questions about the meeting, I'm the fool who's leading the organisation, so please come and see me and talk to me. Thank you very much.
Kirsty, thanks. Beautifully presented, and we do have time for questions or comments. David.
Thank you very much, Kirsty. Fascinating. Sort of elucidating what we were discussing about why does diabetes make glucose. But I wonder with this business of and there's been very interesting stuff about how good glycemic control is, but this bit about the ones who have these very high levels frequently, is that a product of their therapy or an inherent characteristic of their diabetes, in which case, if it's a form of, can you normalise that risk by getting better control of their diabetes?
A really good question. Glycemic variability can be the result of numerous different things. Partly it's medication management and compliance with medication, but also what we've seen in our studies is that a lot of this glycemic variability occurs in individuals who have undiagnosed type 2 diabetes. So individuals who clearly need some sort of medication, but partly because of all the stigma associated with type 2 diabetes, are not diagnosed. So that's probably one of the major causes of this glycemic variability.
Is there an autoimmune component?
I mean, there certainly is an autoimmune component in type 1 diabetes. There has been questions about the development of diabetes after SARS-CoV-2 infection and whether that's some sort of molecular mimicry. The hypothesis is there, the evidence probably is not there yet.
Thank you. Ian?
Kirsty, PBMC is an immunologist's friend. I know they're easy to get and you love looking at them. Are they the appropriate thing to be looking at in these cases?
Yeah, it's a really good question. We've now done this. We've also done these experiments where we've set up an in vitro model of the pulmonary epithelial endothelial barrier, so where we have epithelial cells and then below endothelial cells, just like what happens in the lung. And actually we see the same thing, that hyperglycemia plays a role, but it's not just active hyperglycemia at the time of infection, it's the history of hyperglycemia. So I think this holds true across multiple different cell types.
Robert?
I've got a very complicated question.
All right.
Queensland is going to have the second options in Australia. Do you think every state should have an option, because Queensland is the only one that has free flu vaccine?
I mean, look, I'm not going to do any blatant state self-promotion, but maybe it's because people like beaches and sunshine. I say this as a Melburnian by birth, so I can say this. No, I mean, I think we do need to have more discussions on respiratory viruses as we move into, as the previous speakers have elucidated to, a really changing scenario where we've got changing patterns of influenza, a changing situation with SARS-CoV-2 and the waves, and now we'll have the potential for RSV prevention mechanisms. So I think there is a need to have these conversations and not just depend on the old dogmas of pre-vaccination and, you know, even 5 years ago.
Kirsty, this is like an honours exam. Quick answers.
Okay.
Lots of questions. There's
Okay.
not from Tom.
Thanks, Luke. Thank you, Kirsty. Given your emphasis on the history of what happened to the cell being exposed to high sugars, do you think, or have you looked at, if there's a lot of sugar in the environment, the glucose transporter necessarily will drop. So when it needs to act, and the cell needs sugar to do everything, when it needs to act, it can't in the same way. Have you looked at that specifically?
We haven't looked at glucose transporters, but what we have looked is epigenetic changes, and we can see changes to the chromatin folding and unfolding with a history of glycemia.
One more question from Rod.
Okay.
Oh, sorry.
Thanks, Kirsty.
Where am I looking?
Here.
Oh, thank you, sorry.
Just on the association between SARS and diabetes itself, any sort of thoughts on the mechanism? Obviously, SARS has been associated with all the long COVID symptoms with a huge, spectrum of conditions. So for, the metabolic disorders.
Yeah, I think it's more complicated than just the virus getting into the pancreas. I think you're absolutely right that the sort of chronic inflammation that we see with SARS-CoV-2 could be playing a wide variety of roles, including in the post-acute sequelae of, say, diabetes. One of the things that we're actually currently researching, and this is really cool, is we can actually go back to tissues of people who died in 1918, 57 and 68, and we can actually start looking at their pancreases to see if this is something that we saw in past flu pandemics or if this is really a SARS-CoV-2 specific phenomena. So give me a couple of years and I'll present that work.
Rod.
So thank you. First question is, when a patient says, I look after my diabetes beautifully, why should I have a vaccine? So it's a resistance where people say, look, I'm perfectly healthy, 70, my sugar's good. So maybe they're right, and I say, don't have the vaccine. The second question, will Ozempic be the saviour?
Oh, sorry, what's the second question?
Ozempic, this weekly injection, it'll stabilise my sugar and I'll be better off.
I mean, maybe if you can get it. No, so I think in response to the first question, I would say that you would always need a flu vaccination, even if your HbA1c is great, even if you have perfectly controlled diabetes, because still with well-controlled diabetes, you're still at more risk. So it's just something inherent in the nature of that metabolic condition. And whether or not this will change with Ozempic, I don't know. One of the things we're actually looking at in the context of obesity is whether bariatric surgery actually resets your immune response to respiratory viral infections. The short answer of that is it looks like it doesn't. So this history, this metabolic history really plays an important role.
Kirsty, thank you. Wonderful presentation and great responses.